Good afternoon, everyone. It's time for the seminar. I want to welcome everyone here today. My name is Ann Burke. I'm on the Faculty of Population, Family, and Reproductive Health. And on behalf of that department, it is my honor to welcome Dr. Willie J. Parker as a speaker for our seminar today. To some degree, he needs no introduction, but he is so accomplished that in order to relay some of this to you, I'm going to have to rely pretty heavily on my notes. Dr. Parker, as many of us know, is a reproductive justice advocate who travels as an abortion provider to Montgomery, Alabama, and to the lone remaining abortion clinic in Jackson, Mississippi. He holds a BA from Berea College in Kentucky, a medical degree from the University of Iowa, a master's in public health from Harvard, nobody's perfect, and a bachelor's in science from the University of Michigan. He completed residencies in obstetrics and gynecology at the University of Cincinnati and preventive medicine at UCSF. Many of you in this room may also be interested to hear that he was an EIS officer with the CDC, and he's also completed a fellowship in family planning at the University of Michigan. Dr. Parker's more recent work has focused on violence against women, sexual assault, reproductive rights and justice through advocacy, and provision of contraception and abortion services. He's also the recipient of numerous awards, including the 2013 Physicians for Reproductive Health Dr. George Tiller Provider Award, Planned Parenthood's 2015 Margaret Sanger Award, and he was recently honored by the United Nations Office of Human Rights as one of 12 women's human rights defenders. In addition, he's chair of the board of Physicians for Reproductive Health. I've been fortunate enough to know Dr. Parker for many years and know that he is brave and noble and committed and thoughtful and kind. He is one of these people who is truly making the world a better place, and I know that you share my sincere delight in being able to welcome him as our speaker today.
Thank you. Thank you.
And before Dr. Parker gets started, I've just been instructed to let everyone know for the Q&A session at the end, there's 2 microphones, one on either side. So please come to the microphones with your questions when that time comes.
Thank you, Ann. Good afternoon. I'm excited to be here. You know, I just had a birthday yesterday. I'm not soliciting birthday thing. Yesterday on Facebook, about 450 people wished me a happy birthday, and I didn't know I knew 450 people, let alone them all saying happy birthday. But I say that to say that when you have milestones like a birthday, they prompt you to do things like one, to live gratefully. So in expressing gratitude, I want to start with my colleague, Dr. Ann Burke, who put me on the radar screen, Dr. Bloom, who invited me. Dr. Bloom and I were at Women's Deliver Conference in Copenhagen. And he told me this morning that when I walked through the door, I think he thought my head was going to be this big, because when he saw me, I was on a huge screen that made me much larger than life physically. So when I walked in as a normal person, he was kind of impressed. I must say, as the final thing, that I'm finally happy to be at the Johns Hopkins of Johns Hopkins. And what I mean by that is I've gone to other institutions and they've said that we're the Johns Hopkins of the South. We're the Johns Hopkins of the Midwest. We're the Johns Hopkins. So I'm finally happy to be at the Johns Hopkins of Johns Hopkins. Right? So I was invited to talk about my work, which I consider to be a form of disparities work, and I call it reproductive health disparities. And when we look at reproductive health, when you look at the situation, you're prompted right away to either feel outraged that they exist or feel like they represent an opportunity to address. And so I will illuminate domestically. Hopkins has a reputation for being internationally renowned, and sometimes the dichotomy between being international and domestic, one of the things I wanted to do, my work, I've done some international work, but most of my work has been domestic. So I wanted to take a chance to take an opportunity today to highlight some of the disparities by race and class domestically, and I'll leave it up to you to decide whether or not they're outrages or whether they're opportunities. And because the stark contrast for most of us is along the race continuum of black-white, the additional part of my title was Black Lives Matter with a question mark. And my hope is that when I articulate a framework about how we can work on these issues, we'll find that hopefully Black Lives Matter as a movement provides us with an opportunity to figure out how we can be as impactful domestically as we have been on a lot of issues internationally. So I'm going to give just a general overview of U.S. health disparities in terms of reproductive health from my point of view. And I'm going to describe the framework from which I approach those in terms of social justice, and social justice in particular as articulated as reproductive justice. And I want to define that framework of reproductive justice, and hopefully for many, it won't be an introduction, but kind of make the case for why a reproductive justice framework, if it has not infused deeply into the work of public health, that it should. So I always like to start from this place because oftentimes I'm in spaces where people don't agree with me, or they, especially as I navigate the space between narratives that are empiric and not. The late Senator Daniel Patrick Moynihan from New York, he's one of two New Yorkers that I'm going to quote before I start, said that everybody's entitled to their own opinion, but nobody's entitled to their own facts. The second New Yorker, I would love to have seen a dialogue between this person and Senator Daniel Patrick Moynihan, and more cogent to what we're saying today is, oops, that didn't show up. I'm going to quote the second person, and that's Jay-Z. And Jay-Z said that women lie and men lie, but numbers don't. And so when we're talking about issues of reproductive justice and health disparities, the numbers don't lie. So I'm going to run through some of those numbers a bit to kind of make the case for the disparities with regard to reproduction in this country and why they call for social justice analysis and a framework that would allow us to remedy those. So starting right off the bat, you know, I'm not going to make the assumption that we're in the School of Public Health. I always think about my colleague, Dr. Burke. They have a fellowship, and I don't know to what degree you all would be exposed to these numbers, but I'm just going to, if you'll indulge me for a minute, if they're numbers that you already know, I'm going to use them to make my case. So we know that of the millions of pregnancies that occur in this country, half of them are unintended, but unintended does not mean unwanted, because of those pregnancies that are unintended, over half of them continue for birth, but the half that doesn't continue ends up in abortions. And if we look very graphically over time, that contrary to what people who oppose abortion would have you believe, the rates of abortion have fallen, and they continue to fall. But you would be led by people who oppose as they spin the message to think that abortion is on the rise. Well, actually, it's on the fall. It's declining for multiple reasons, and everybody's taking credit for it. But like many things, the devil's often in the details, and if you disaggregate data, as researchers, you know that sometimes it will illuminate things that you didn't see when you look at aggregate data. And abortion and reproductive and contraception are no different. So when we look at unintended pregnancy, if on the premise that abortions come from unintended pregnancies, which are unplanned, unwanted pregnancies or wanted but legally flawed ones, it would seem if abortions are dropping in this country, and we think that that's a good thing socially, that it's not that way for everyone. So while overall unintended pregnancy rates have stagnated or they've fallen slightly, unintended pregnancy has increased in some parts for some folk and decreased for others. And so if you have a decreasing rate for one sector and an increasing rate for another, it makes sense that arithmetically that you can have a flattening or a slight decrease, but for the population where it's going up, that would not be a reason to celebrate. So some of those populations where, if you look at the people who are at risk for unintended pregnancies, poor women account for 16% of the women who are at risk for an unintended pregnancy, but they make up 30% of the unintended pregnancies. So disproportionately, poor women have more unintended pregnancies than they should represent in the population. And and like I said, if abortions come from unplanned, unwanted pregnancies, then it's not rocket science to understand that people who are increased risk for unintended pregnancy, also the people who are more likely to have an abortion. So if you look at by percentage of poverty, if you remember, I said that national poverty rate of this country is about 16%. 42% of the abortions that happen, they occur to women who are living in poverty. And poverty and race are not synonymous. They're often the same population, but they're not always synonymous. And so if you disarticulate further and look at unintended pregnancy by race and ethnicity, Black women, again, although they account for 14% of the women at risk for unintended pregnancy, they account for 26% of the women who actually experience an unintended pregnancy. And we'll get into why that might be in a little bit. The same for Latino women. Again, they account for, and these numbers might be a little bit dated because some populations are growing, but the ratios hold true. Latino women make up about 14% of the women at risk for unintended pregnancy, but they make up 22% of the women who have unintended pregnancy. Now, if you remember, I said abortions come from unplanned, unwanted pregnancies, or wanted but lethally flawed ones. When you put those two groups together, although numerically they're not the larger sector of the population, proportionally, when you put Black and Latino women together, you have Black and Latino women making up proportionally over half of the abortions. And the significance of that is that there have been people who've been able to do what I call epidemiologic mischief. And what I mean by that is people will take these proportions based on population representation and create the notion that there's some conspiracy to kill Black women or Black babies with a Black genocide phenomena that for the last few years has been notoriously in circulation, which is, I find ironic in this 100th year of Planned Parenthood's anniversary, where they've made significant gains in protecting the health and lives of women, that we're still questioning what the motives of Margaret Sanger were 100 years ago when she founded the birth control lead that became Planned Parenthood. So again, while proportionally Black and Latino women have higher rates of abortion, the absolute number of abortions that happen in this country is higher for white women because they're a larger proportion. They're the largest population sector. So those are some of the numbers, and so besides the consequence of leading to abortion, unintended pregnancy also has prognostic significance for the outcomes of those pregnancies that continue. So we know that if a pregnancy is unintended, but even if it continued, those people, the people who have unintended pregnancy, women where that was the context in which they conceived, they're less likely to seek prenatal care. And that means that we miss opportunities to triage and to intervene on problems that will result in negative health outcomes for the woman and the baby that she's going to give birth to. We know that prognostically, with regard to life chances and life trajectory, that unintended pregnancy limits a woman's educational and professional aspirations. And what that means is that women who are already in poverty, who have higher rates of unintended pregnancy, who have higher rates of abortion, if they continue their pregnancy, you have people in poverty giving birth to folk who are in poverty, so you have the concentration of poverty, which exacerbates all of the outcomes related to poverty. In addition, these prognostic indicators are, again, worse for people of color and poor women, again, two populations that are often synonymous but not always the same. So I want to run through some of the metrics that we use as indicators of population-based health. And one of the big ones where we use in terms of for international comparators would be like maternal mortality and infant mortality. Maternal mortality, there are some striking parallels and ironies in the disparities that we have in our country, and maternal mortality is one of them. In the U.S., as one of the materially most wealthy nations on the planet, of developed countries, we always hover right in the 30th. We're ranked 30th in terms of maternal mortality. And part of the reason that this is a case has a lot to do with the disparities in reproductive outcomes that we observe by race and ethnicity and class. We know that African American women, depending on which population that they live in, can be anywhere from 4 to 15 times more likely to experience maternal mortality. And the reality is, in this country, it is on the rise. The metric, and when I say it's unchanged over the last 5 decades, even though we've had some improvement, but now we're on the rise, we have not been able to close what we call the black-white gap, the disparity between black women and white women. When we use white women as the comparator, the disparity in outcome when we look at things like maternal mortality. We know that in maternal mortality, during my EIS experience, I looked specifically at maternal mortality and looking at mode of delivery and disparities related to maternal mortality. And what we know is that no matter whether you're talking about the gap or in general, there are many factors in maternal death that are potentially alterable. And so when we look at the fact that women living in poverty or having lower rates of early enrollment in prenatal care, we missed opportunities to alter some of those factors that are deemed to be significant when it comes to maternal death. So this is a disparity that really troubles in a country like ours, that these kind of gaps exist, and that the rates are increasing and maybe these gaps are widening. When you look at sexually transmitted infections as a proxy for some of the common pathways around having prognostic value around health and both reproductive health and overall mortality, what we know about, we've gotten better at reducing HIV, AIDS in some populations, and for some people it's gotten worse. We know that African American women and Latino women, while they make up a smaller proportion of the population, of the people who have HIV/AIDS, they're 14 times more likely to die from HIV/AIDS. Even in the era where we've turned HIV/AIDS into largely a chronic illness, African American women of color and poor women are still dying at higher rates to the comparators. And we know, again, African American and Latino women account for over 66% of the diagnoses, even though, again, they are a smaller portion. Again, being last in what you would want to be first in and first in what you would want to be last in. There are multiple, as we say, our hedge in medicine, most things are multifactorial, multi-causal, which means that's a really clever way of saying I don't know. But there are multiple things that factor into the phenomena that we observe. But what we do know is these are oftentimes indices of lack of access to comprehensive medically accurate sex education, which will allow us to alter the risk behaviors and the risk factors that could lead to infection, as well as access to comprehensive health care. We look at things like infection with, we always, the HIV/AIDS is the gorilla in the zoo, but when we look at other ominous indices around sexually transmitted infections, we know, and we should, if we're not concerned about gonorrhea, we should be concerned now that we have drug-resistant strains of it, and which means that significantly it's about like HIV in terms of that not being much we can do if somebody's infected with it. We know that, again, the disparity, African American women have 18 times the risk of infection with gonorrhea, 8 times the risk of infection with chlamydia, and Native American women have 5 times the risk of infection versus their white comparators. And then when you look at things that we thought we were on the verge of eradicating, like syphilis, there's been a rebound of infections with syphilis in terms of increased in Native American populations, Asian API populations, compared, again, multifold times compared to their comparator group of white women. And so, part of these other, the significance that these bear with regard to HIV/AIDS is as being infections that cause ulceration or a breach of the mucosa in the genital area. They function as facilitators for the disease process that we're most concerned about, like HIV/AIDS. And then when we look at the one thing that we know is really a sexually transmitted cancer, or exposure to human papillomavirus. We know that HPV is more prevalent in the multiple strains, and more prevalent amongst racial minorities, and what's significant about that is we know that 90 to 95% of the cervical cancers that we are making progress in decreasing deaths from cervical cancer, but that there's stratified success. Even though we have falling rates for all as we get better at screening for HPV and treating HPV, when it comes to cervical cancer deaths, as they fall, they continue to remain higher for Black and Latino women. And that could be linked to access to more sophisticated screening and triaging mechanisms, and actually getting people into follow-up. When their care exists, it doesn't matter, if people can't get to the care that they need. So, to transition you a bit from, you can talk to numbers, and in a room full of people who like research, you don't glaze over, but a lot of people, their eyes glaze over when you talk about numbers. But what I never want to lose sight of, and I don't want you as researchers to never lose sight of, is behind those numbers are faces of individuals, and in particular on reproductive health issues, the faces of women and children. So I very intentionally constructed this slide to show the faces of women and children. When we talk about the numbers, this is what and who we're talking about. And when we talk about the most vulnerable members of our society, how we treat the most vulnerable member of our society says a lot about who we are as a society. So when you look at these numbers and these disparities, and you look at the people affected, and you look at these beautiful mother-baby pair bonds of various backgrounds, and you look at the realities that I just highlighted to you, it invokes what I call the Nancy Kerrigan principle. Wow. Now, I don't know if you all remember when she was attacked by her fellow competitor and was banged on the knee, and the slide, the only thing she had was why? And I find myself sometimes asking this question when I look at these health disparities and reproductive health disparities that we have. Well, let me see if I can make some sense about, as researchers, everybody in this room knows that cause effect is very difficult to prove, but you can have strong associations, and you can kind of name some of the likely culprits. And so when we look back at why we are at this era where we have limited access to the things that people need to achieve their reproductive health goals, and to live what we would call responsibly in the context of human sexuality, one of the biggest barriers, or one of the things that kind of set things back, was this emphasis on abstinence education during the Bush II era. Representative Henry Waxman, who's no longer in Congress, did a very explicit analysis of the impact and the role of spending money on abstinence-only education. And the term abstinence-only education means when you have an educational or motivational program that teaches from a very narrow, specific moral or religious understanding that a certain context or way of constructing a marriage in the context of a monogamous sexual relationship is the standard for sexual activity, and that sexual activity outside of the context of marriage has harmful. So it's kind of using the boogeyman principle to say, oh, you're going to get something really, really bad happen to you if you have sex with somebody who's not your spouse, or if you have more than one partner. So $100 million was spent for abstinence education. And what that meant practically was that teens were denied access to medically accurate information. For example, they were left with birth control myths. And when your imagination runs wild, in terms about the types of condoms, this is a very bad joke, I get it. But in terms of, okay, if you don't know anything about pigs and porcupines, and you're like, so okay, a condom, so what's the condom for a porcupine? It's like, so the point is, when people don't have information, they end up with very inaccurate or silly information. So what was some of the misinformation that was actively promulgated on the websites of the government when during the Bush years? One, with regard to, on the CDC website, they had information like In heterosexual sex, condoms fail to prevent HIV a third of the time. That's just blatant misinformation. The popular claim that condoms help to prevent spread of STDs is not supported by data. And that was just blatantly misinformation, but what are you gonna do? And then they quoted pregnancy rates. Maybe condoms should have been used as infertility treatment based on these numbers, right? And so it also led people, again, when people have misinformation, they make bad decisions. So what you had almost 1 in 5 young adults believing that douching could prevent a pregnancy. And then you had young men believing in postural contraception, that 1 in 5 young men believe that sex standing up reduced the risk of pregnancy. So again, you have people with misinformation, and if you have misinformation or no information, you end up with things that seem reasonable to you, but you don't have any basis. And somebody said that what you don't know won't hurt you, but we all know that sometimes what you don't know will kill you. So this lack of sex information was documented with survey research by the national campaign. What they found when they surveyed was that 1 in 5 unmarried young adults said that they had never had any sex education in school. It bore out in some of the phenomena that we're seeing. And then you had, for the ones who did receive sex education, 1 in 4 said that they had received it before the age of 15. It's like telling your 7-year-old now, here's how to fix a car, right, when they're 7, but they don't drive a car. And then so when they actually need the information, it may not be relevant. You give them information when it's not relevant to them, and then when they need the information, you deny access to it. It just becomes a self-fulfilling prophecy. Ignorance is not bliss. Sometimes ignorance is calculated and policy-driven. So what you don't know, again, will harm you. So women who lack basic knowledge about contraception, they know where babies come from. They just never thought that an unplanned pregnancy would happen to them. That resulted in 750,000 young women becoming pregnant. So what have been so we know misinformation has been one of the things. What have been another factor leading to, in this case, reproductive health disparities around unintended pregnancy having the prognostic significance for continued pregnancies, and unintended pregnancies leading to abortion. What stood in women's way? And we have to say, with regard to contraception, part of my research during my fellowship was related to reliable methods of contraception for men. And I used to give a talk called Male Contraception, If You Build It, Will They Come? And every pun intended, because what seemed to factor into matter and with regard to men is the inability to discern between sterility and potency. Because when you said sterility to a man, he heard impotence. And so the methods that could not reliably reduce gametogenesis or block their transmission, you had to be able to do that scientifically, but from a health marketing standpoint, you had to be able to convince that man that his sexual functioning was not going to be affected. And so in the absence of that information, because we've always been 5 years from having, for the last 30 years, we've been 5 years away from having a reliable method of male birth control. The challenge then becomes what has been the barriers for women and couples to reliably contracept? Well, if we look based on the National Survey of Family Growth, we can discern really quickly that the most commonly used methods have not been the most effective methods, and the most effective methods have been minimally used. The most commonly used methods with regard to reliability that are at use in this country have been pills and sterilization. Sterilization is problematic in that it's not reversible. So if you have somebody being sterilized when they have life goals of having future children, it's problematic. And if you have people relying on pills, as I'll show you in a minute, who you would think that the longer they use the pill, the more effective they come at using it, but that they end up becoming less reliable. That will show how it is problematic. Then one of the most extremely effective things, now the numbers are a little bit better around IUD use in this country now. We've had a little better uptake. But the reality is probably the best, most cost-effective method has been the IUD, and it's probably been one of the ones that has been the least used. And then So I showed you that the most commonly used method for women in this country has been birth control pills. But this study shows that when you looked at over 3 months use and you graph the likelihood of women using the pill correctly or missing pills, correct use, by month 3, if you look at the yellow column, you would think that over time, as you get better with your pill, that number would go up. Well, what you saw is correct use in month 3 went down. And the likelihood that people miss 2 or more pills went up. We know that when you miss pills, you are more likely to have, even if you continue to pack it, you're more likely to have a breakthrough ovulation. So that's when people say, oh, the pill doesn't work for me. What that usually means is that there's been there's been user failure. Incorrect use. Failure is a strong word. But people who are intending to contracept, that method doesn't work for them because they cannot reliably take the pill. So you see, what you have here is the thing that we're most reliant on has not been the thing that's been most successful. So let's say if the gold standard, when I'm counseling my patients about getting an IUD, and they ask me would I use it, the strongest vote I can use to say is if I had a uterus, it would have a Mirena in it, right? If I wanted to have reversible, long-acting method of contraception, that's the strongest endorsement. They often want to ask, well, would you put one in your partner or your mother or your, absolutely, but I think if I had a uterus, it would have an IUD in it. So, one, because it's one of the most effective long-acting methods around. Number 2, for people who may have contraindications with regard to risk factors around a disease process that might be hormonally dependent, it's safest that way. There's high patient satisfaction when we actually look at people you ask people how they feel about their device, they are satisfied with it. People who are satisfied will continue a device. And it's very cost effective because the decision, I used to tell my patient, if you give me 3 to 4 months of a side effect profile with an IUD, I'll give you 3 to 12 years of reliable pregnancy prevention. A lot of times early on, with the irregular bleeding and maybe some of the cramping, in the patient that's appropriately counseled, you can get them through that period. But if you don't counsel and select appropriately, that person going, I'm bleeding nonstop. I've been bleeding for 4 months, and then you do their hemoglobin. It's actually higher than it was when you inserted the device. But in their minds, the temporal relationship between this device and whatever it is that they're feeling becomes a battle between you and them keeping the device and them feeling coerced versus encouraged. The other thing about the IUD is it has rapid return of fertility. As soon as you remove the device, theoretically, after normal resumption of menses, fertility is there. Okay. So if IUDs are so wonderful as I'm going on about, why aren't they being used? One, you can't use what you don't know about. So there's a lack of awareness about the availability of IUDs. Number 2, there are misconceptions about IUDs, and I'll hit some of those in a minute. Number 3, there are misconceptions amongst providers. There's a long-standing history of IUDs that were problematic, and then they went off the market for a time. And a lot of people don't know that after they went off the market, they came back onto the market in 1988. And so now we effectively have 2, now maybe a third IUD on the market that is FDA approved, but those are not the IUDs of old that many providers who practiced pre-1988 or many people who heard stories from their mothers or grandmothers about. It's not the same device. And so, but we're still competing with the myths of the old devices. One, there's also lack of physician training. You can't place a device that you don't know how to place. And again, there's, because of the exclusivity around patent laws where people can charge a lot of money to recoup the cost for their research and development, the cost of obtaining an IUD might be cost prohibitive up front. Now, lack of training, again, the most the things that predicts the use of an IUD the most is going to be the appropriate candidate and educating them. So again, this picture can't make too obvious the notion of making sure you choose the right client to counsel for an IUD, because you're not going to have uptake or retention if you don't choose the right client. So what's some of the misinformation that's been out there about IUDs? Number one, more than half people believe that IUDs can cause an infection and that that will make them less likely to use the method, versus particularly the progestin-containing IUD makes ascending pelvic infection less likely. Almost a half of the people believe that IUDs can detach and wander around through the body and cause problems. 40% of women believe that an IUD insertion is a surgical procedure, and a fourth of people believe that IUD can't be stopped early, and in part that may be related to, again, something I alluded to a little earlier, where when we look at the initial cash outlay of the device, if we haven't appropriately counseled, or someone's enthused about getting the IUD, you place it in and then they show up 3 weeks later and want it out. And you know, I just put a $750 IUD in you, so now you know that if you get them through that first 3 to 4 months, 3 to 4 months with the device in place, then sometimes providers become distracted by how much the device costs, and then they begin to overlook the autonomy of the patient that they should respect. So even if the patient had the IUD at 3 weeks and it's $1,000, when the patient says, I want it out, they should be able to get it out. So this is not a far-fetched myth for some if they've heard anecdotally about folk who were being forced to continue the device for a certain amount of time, or preemptively saying, now, if we put this in you, you got to keep it for 3 months. And then you say, okay, put it in. Then like they come back 2 weeks later, it's like, I want it out. No, you remember, we said 3 months, right? And so you start to, you lose sight of the fact that you have to respect patient autonomy. And if you're having to take an IUD or a device out after about 4 weeks, then what you should revisit is, obviously people, you know, you do the best you can, but what you should revisit is whether or not you're being clear in your patient education and your patient selection for the device. Myths and misconceptions about the discontinuation of birth control are the things that we're going to be competing against. You know, even you have the most effective method, if you don't effectively combat the mythology and provide appropriate education, what you end up with is an unplanned pregnancy, or and you have to wonder if you now have a pregnancy where you have to determine whether or not it was unplanned, with the prognostic significance, as I said earlier, of what an unintended pregnancy means for the healthcare seeking behaviors during the pregnancy, not to mention whether or not that person is going to contemplate ending the pregnancy. The other thing I put this in here to remind is, you know, I call it the stratification of sexuality, when we have become more vested in restoring sexual functioning for both men and women, because we now have drugs for women who have sex functioning disorder. But the degree that there are barriers to empowering women and men to control their fertility are reflected in the degree of difficulty we have in accessing contraception, as opposed to drugs or devices that restore sexual functioning. So I can't make this case too strong that, again, as I said earlier, when it comes to poverty, that overall progress about the fall in abortion rates has been a mixed picture. As you can see, women above the poverty level, their unintended pregnancy rates fall, but women below the poverty level, we're seeing great increases in the number of women who have unintended pregnancies. Now, an effort to make a difference was the Affordable Care Act, so that we could make access to contraception, preventive services, and thereby liberalize access to things that allow people to control their fertility. and thereby hopefully make being female not a pre-existing condition. But we're still in the process of trying to implement that, and there's still people fighting to make it go away. Another thing that I want to talk about in terms of that that maybe modulates the number of unintended pregnancies is even when you have access to contraceptive services, there's the context of reproductive coercion, which is another expression of intimate partner violence. And this slide shows that sometimes abuse doesn't always have to result in a bruise. We know that 1 in 5 people who are accessing, in one study, 1 in 5 people who were accessing a family planning clinic reported reproductive coercion, pregnancy coercion, and I'll talk about that in a minute. 1 in 6, even when they had birth control methods, report sabotage. 1 in 3 reported 1 in 3 people who have intimate partner violence. Also, if you ask them about their history around sexual agency, they will report reproductive coercion. And unintended pregnancy rates, it's not rocket science to understand that there's higher unintended pregnancy rates around people experience reproductive coercion. So what is reproductive coercion? Well, first of all, pregnancy coercion is in the context of a partner or bonded relationship, people being forced to get pregnant. They're told not to use birth control. Their partners threaten leaving or break up of the relationship or going outside the relationship to get somebody else pregnant if their partner won't become pregnant. And then sometimes there's just the outright physical abuse that's associated with trying to force someone to become pregnant. When you look at another aspect of that is birth control sabotage. So even if someone has access to a method, you can have partners who agree to use condoms but take it off during sex. They'll poke holes in the condom. They'll break the condom on purpose. They will take if a woman's on pills, take her pills out of her purse. And so there were times where I will recommend Depo-Provera or an injectable to a patient. If not, place an IUD where we would cut the strings flush because anecdotally I have stories of patients' partners pulling their IUDs by finding the strings. They will prevent them from accessing the clinic to get birth control, and then there'll be forced sex without a condom, which also factors into the transmission of the STIs that I talked about. Oftentimes partners, even if a woman's unable to escape a battering situation, she might at least lobby to ask her partner to use condoms during sex, given that she can't control his extramarital activities, but they will, even when they know that they're out having risky sex, they will women aren't empowered to negotiate around condom use, even when they know that there's high-risk behavior in the other part of their bond. So pregnancy options, all women have the option. Actually, we would say that you have non-directive counseling, you have 3 options there. You can parent, you can consider adoption and abortion, but really you have 2 options of continuing a pregnancy, which can lead to either adoption or parenting, or ending a pregnancy, which is abortion. I make that distinction of just 2 options because sometimes people are much more comfortable and overly reliant on the notion of considering adoption, and sometimes that is culturally insensitive, particularly when you look at people who've had their sexuality commodified. I think specifically about the number of African American women who find it difficult to relinquish parental rights once they see a baby. I very seldom saw Latino women in the context of considering adoption. And then even for the women who considered adoption, in foster care, disproportionately African American babies who are placed in foster care age out because those babies are unadoptable. But one of the reasons I put this slide to remind me is sometimes when it comes to the politics of respectability around reproduction, we are sometimes more comfortable talking about contraception than we are abortion. and Surgeon General Jocelyn Elder said something at a ACOG meeting that just struck me, and I've continued to use it, particularly with regard to people who want to have a heavier conversation in the context of abortion around trying to get a patient to choose a method and to make uptake happen in that conversation. She said, "I've never seen a woman yet who needed abortion who wasn't already pregnant," which is to say, let us recognize that sometimes the only thing that abortion and contraception have in common is that the pathways that they share in common. An abortion situation may be an optimal time to offer an opportunity for somebody to contracept, or it may be the wrong time to talk about contraception. But let us not engage in coercive activities simply because we are vested in looking at abortion as a social ill and as a societal or personal failure, and we insist on having a heavier conversation about contraception than we ought to in that context. So if we have a social justice framework to deal, like, if we look at all of these things, so we've medicalized them and we've tried to gain access, but what's another way to look at it? I think the approach to these disparities that lends themselves well, I think probably one of the best approaches has been a public health approach if it is informed by a reproductive justice, because public health largely has social justice as a core principle about promoting human rights and responsibilities, and also doing so with regard to resolving disparities, doing so in the most vulnerable and needy groups. If social justice is its core value, then I would argue that if you put social justice and reproduction together, a concept that if it's not one that's articulated, one that I would advocate in the public health realm is articulating a framework of reproductive justice, which is a bit different from a reproductive rights framework. Let me see if I can illustrate. In reproductive rights, we are insistent on ensuring women and families the right to prevent a pregnancy that they don't want by having access to medically accurate sex education and access to contraception. And then we insist on the right of women to end pregnancies that they couldn't prevent or that they don't want. If you stop at those two, most reproductive rights organizations, you would have what their core principles are. But they would then, if you stop there, then reproductive rights organizations are at a loss about how to deal with folk who also have considerations around having the resources to parent the pregnancies that they want and to continue. And I think that's where a reproductive justice framework is a bit broader, because it allows for the intersection between people who are modulating about contraception and abortion and parenting. It's a broader framework. And so if you put the concern about the right to parent and having the resources to parent in a reproductive justice framework, is broader, and it allows for collaboration. So people who want to talk about birth justice and abortion access have a model and a means of collaborating. Whereas if you stick with a reproductive rights, they might not necessarily see access to prenatal care as a primary interest of theirs. And then I throw in my reproductive justice stool has a fourth leg, and that is that all humans are entitled to primary sexual pleasure. And the reason I throw that in is because where LGBTQ and non-gender conforming issues have a role or a place in a reproductive justice framework, is what our LGBTQ identities and contraception and abortion do is contraception and abortion uncouple sex from procreation. LGBTQ identities uncouple sex from procreation. And so a reproductive justice framework allows them to work together as they shift the framework away from a heteronormative nuclear family model that may be limited as people now have new ways of actualizing their freedoms to structure their families and to live their lives as they see fit. So I say, on that basis, a reproductive justice framework may be creating another way to analyze and to look at it, like complex mathematical modeling in an epidemiology model of a way to look at the way in which particular identities interact And that becomes critical if you're going to come up with solutions that are going to be sustainable and workable in a pluralistic society. So as I close, let me say that Dr. King said it best: injustice anywhere is a threat to justice everywhere. And if that is the case, if we are concerned about the things that I just articulated to you, it will lead you to proclaim with the late Nobel laureate and Holocaust survivor, Mr. Elie Wiesel, when he says, "Our lives are not our own, they belong to all those who need our help." So I want to thank you for your attention, and I'll now take any questions that you might have.
I would just remind people to please use microphones. Yes, I would be hard-pressed in this audience to imagine that there are no comments.
Hi, Dr. Parker.
Hello.
Thank you for coming. Although this isn't in your talk, you have written and spoken in other contexts about your role as a person of faith and how that's influenced the work that you do. And so I would just, be interested to hear a little bit about your thoughts on that.
Sure. So first of all, I think that faith and religious identity, because we have the freedom of religion, I think there are personal identities. The freedom, one of the things that I think is lost in our country is that the freedom of religion also means creates the capacity of the freedom from religion. And yet people are insistent on expressing their faith identity. And one of the ways in which it's been most problematic is people have used their particular religious and faith identity as a rationale to deny people their reproductive rights, and they find their particular sacred text and their particular understanding as a reason to lobby legislators to actualize their worldview. And that for me felt problematic because I share the same faith tradition with many of the people who are leading that charge, and I find that since we live in an unofficial theocracy in this country. We don't have a national religion, but we do. And that has been very effective in leveraging policymaking. So given that we are now in a reality where people are leveraging their religious understanding to create policies that limit people's opportunities, it made sense to me that the appropriate counter-narrative would be to leverage my religious understanding to increase the ability to think about these issues in a way that would be just and that would be empowering for people to live out their vision. It's not as much strategic as it is, that's the reality. The first 12 years of my practice, I didn't do abortion care, and it's largely because I had to do my own personal values clarification growing up as a fundamentalist Christian in the South. And so, whereas the people who oppose abortion find in their religious understanding the imperative to deny people access to abortion, I find in my moral imperative the right to actualize people's reproductive and social justice rights. So that's probably pissed off more people who think that they have the moral high ground, because it's easier to dismiss my abortion work as me being a heathen and that I do this work because I don't care and I have no religious or moral framework or understanding. But it becomes problematic when I have the same religious tradition and can push back and can ably say that, there's more ways to understand. So that has made my work more personally gratifying, but in some ways it's made my work more dangerous because I find that some people they're more pissed off that I claim a faith identity than they are about actually the fact that I provide abortions. So I think in this situation, we're never going to banish religious identity from the public space. And given it's there and it's having a pronounced effect, I think the appropriate counter-narrative is to call for people who have a faith identity, but who whose identity is rooted in justice and compassion to also get involved in the public conversation.
Oh, thank you so much for your talk. It was great. So I appreciated that you brought up LGBT issues. I think as someone who is a young person who kind of works within the reproductive justice movement, what we're seeing from a lot of young folks is kind of realizing that actually not everybody who can become pregnant, who might need an abortion, who might need contraceptive, identifies as a woman, and kind of making a push for more gender neutral language, so like pregnant people, et cetera. But then you kind of have that pushback. It's not always, but a lot of the time it is kind of older versus younger folks in the movement, and older folks, kind of being like, well, why can't we call the war on women the war on women if it's kind of this gendered attack? Our foes clearly have, a very gender binary focused critique, kind of how they think of things. So my question, I guess, is how, do we reconcile that these attacks that you've mentioned are very gendered, at the same time including all individuals within our movement?
Sure. Thank you. That's something that I've wrestled with and I continue to wrestle with because you didn't do to me what I thought was going to happen. I thought you were going to ambush me at the mic and say, "Oh no, no, I'm teasing you." But I have had people do that in terms of asking me as a man how I feel about the narrowness of gender binary language and the need to be more inclusive. And so as a man, for me to tell women how they need to articulate their struggle for their rights and reproductive rights. And so one of the things, I'm still doing my consciousness raising around that. I do think one of the things that has to happen is there cannot be an oppression Olympics. We cannot allow people who have various forms of oppression. One of the powers of RJ in the intersectional analysis is that it's not a zero-sum game. Most of us wear multiple identities, right? So I'm a straight, black, Christian man. There are 4 identities there. Which of those is my most essential identity is the one that I feel most empowered or oppressed by. The goal or the power of RJ is that it's an analysis that does not require it to be a zero-sum game. As a man who doesn't have a uterus, who will never have an abortion, I am no less passionate about reproductive rights because it is a consequence of, if anybody's denied their rights, it's a compromise of my humanity. So I'm not just being a good guy when I do my work, it's about doing the work of human rights work. What it means for us as we have our competing identities that don't have to compete, but that we all wear multiple hats. I think the best thing is to have honest disagreement and to stay in dialogue and in conversation with each other. I think the late Howard Zinn said it best. He said that the cry of the poor is not always just, but if you don't listen to it, you won't know what justice is. And what that meant to me was to call people into a relationship where during the 15th Amendment battle, when women's suffrage women who were instrumental in the abolitionist movement, once the South lost the war, the white Southern Democrats were trying to pick off the women by saying, okay, are you in favor of a black man getting the right to vote before you as a woman? And so they now had to weigh their cultural identity as white folk and their gender and how they were going to weigh in. And there was a big beef between Susan Anthony and Frederick Douglass about whether or not they were going to support the ratification of the 15th Amendment. So I'm saying we know how the story ended up, and we know in 1920 women got the right to vote, but there has to be honest disagreements, and it has to be done in the context of not allowing generational issues or gender issues or racial issues to kind of be a dividing force. There has to be honest disagreement. And I think you have to be in relationship and conversation with folk. So that's a big battle that's going on. I thank you for raising that issue.
Hi, Dr. Parker. I was wondering that as a provider, what is something you would personally like to see from the national reproductive justice movement that you think would be really beneficial?
I think I would like to see a better distribution plan of the resources that we are creating. We have nursing students for nursing students for choice. We have med students for choice. We have family planning fellowship, where we have the Ryan residency program, where we're creating, training people, where we're retarding the graying effect of abortion providers, where younger people are being socialized into abortion being a fundamental right. They're seeking out training, and yet some of them will get the training and they won't go practice. And some of those of us who have subspecialty training, when we finish, we stay in places that feel safer. And so what that means is that we're creating this incredible resource, and are there like 200 of us now that maybe have post-residency training in family planning to include family medicine docs and OBGYNs, and yet the abortion map in terms of abortion providers in a county hasn't changed one bit. So what I'm saying is I'd like to see us kind of strategize on how we're going to, one, create the resource and then kind of distribute it. How do we, everybody doesn't need to be able to do a second trimester abortion. That's when you talk about 20 weeks, that's about 2.5%. Can we regionalize that expertise and make sure within a region that everybody somewhere has access to a second trimester abortion provider? And then can we, for the first trimester, which is the first 12 to 14 weeks where 88% of abortions happen, how do we make sure that people who can do that go to places where the need is? Because as long as we create this resource but we don't distribute it, what are we really, really doing? So we need to figure out a way to distribute this resource so that everywhere a woman's reproductive rights and reproductive access doesn't depend on her zip code.
Hi, and thank you for your talk, and thanks for the work that you're doing for women everywhere and for women of color. I wanted to ask you about this alarming trend that we have of states in the past couple of years introducing new legislation to restrict abortion access, or in some cases even criminalize abortion. And I was wondering if you'd comment on how this trend got started, and given our current political atmosphere, where you think that's going to go.
Well, I had the privilege of being in the room with some very smart people this morning, and we were having just this conversation. But one of the things I think in terms of going all the way back to why after the Emancipation Proclamation in 1865 freeing the slaves, and yet the South was able to kind of regain their dignity by enacting legislation that even though they couldn't institute slavery, they were able to pass laws that practically reintroduced slavery without introducing slavery. In that same regard, given that for the last 40, what are we now, 40, the Roe was passed in 73, 2000, 43, 44 years post-Roe, it's not going anywhere. It doesn't look like it's going to go anywhere anytime soon. So there's been a devolution down towards state-based regulations or barriers, primarily because we don't have a right, a constitutional right to health care. That means that at the state level, decisions about health care and some other things get to be made, and so states get to pass their rules and their laws. So there's been a very intentional devolution down to the state level to, given that you can't overturn Roe, to functionally gut it by having restrictions in various states. So what that means is the solution is not presidential, it's legislative, right? That means that state laws happen based on the voting activities of people, and I'm going to be partisan here and say on November 8th, vote blue and you know who. But the real solutions are, how do we remake, part of where we are now, where we are, is in 2010, the first midterm election of President Obama's presidency, there was a reactionary to the fact that there was a black president, and it swept in the Tea Party and all this voting on the basis of race. Let's take our country back, whatever that means. And that ushered in flipping of whole legislatures so that now you have conservative governors, conservative legislatures, and it just gave carte blanche to ALEC, which is the organization that introduces template legislation so that people can just draft legislation and introduce these bills. If you write it this way and you write it, and now you got the legislature, you can pass the laws that we're seeing, the explosion in the laws. So I say the solution, what the prognosis is, one, we get a president that will eventually get a chance to set up the Supreme Court, so that we now have 2/3 of the government that are set. But the real flip and the real difference at about what it looks like in the 50 states is going to be at the ballot box. So it's going to be, yeah, choosing the president, because the president's going to choose the Supreme Court. But it really, at the end of the day, a president who's not forced to greatness by having a legislature that introduces bills that reflect the values of the people that put them there, we're going to see more of the same.
I regret that, with my apologies to those who would like to ask questions, we must draw this to a close.
Okay.
So please join me in thanking Dr. Willie Parker.